السلام عليكم ورحمة الله وبركاته. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. This is a video recording for the physiology lectures on arterial blood pressure and its regulation in the cardiovascular block. These are the active learning objectives, the intended learning outcomes, the ILOs for these learning activities, and as usual here we have the recommended learning resources. In physics, pressure is defined as the force over the surface area. In biophysiological and biophysical terms, blood pressure is defined as the force which is exerted by the blood on a vessel wall. The force exerted by the blood against a vessel wall. Physiologically, blood pressure is an important physiological characteristic of our body, because it is the force which drives blood along the blood vessels after blood has left the heart. Thus, without blood pressure, nutrients and oxygen and proteins cannot travel from the arterial side of the circulation to the venous side of the circulation. As blood flows through the systemic and pulmonary circulations, friction develops between the moving blood and the stationary walls of the blood vessels, because the walls of the blood vessels remain static, they do not move. Had they been moving, had the walls of the blood vessels been moving, friction would have not been developed between the moving blood and the moving walls of the blood vessels. But this is not the case in the body. In the body, the walls of the blood vessels remain stationary, and friction hence develops between the moving blood and the stationary walls of the blood vessels. The vessels therefore tend to resist the movement of the blood through them. This resistance is known as the vascular resistance. The resistance to the flow of the blood through the systemic circulation is known as the systemic vascular resistance, and similarly the resistance to the flow of the blood through the pulmonary circulation is known as the pulmonary vascular resistance. As the systemic circulation is a much bigger circulation than the pulmonary circulation, the systemic vascular resistance is much higher than the pulmonary vascular resistance. In fact, the ratio of the pulmonary to systemic vascular resistance is approximately 1:6, which means that the systemic vascular resistance is 6 to 7 times higher than the pulmonary vascular resistance. It is because of the resistance which the blood meets as it flows through the blood vessels that we need the heart and the cardiovascular system in order to generate pressure, and with this pressure the resistance is overcome and blood flows along the blood vessels. How do we measure the arterial blood pressure in the systemic circulation and in the pulmonary circulation? In the systemic circulation, arterial blood pressure can be measured directly by introducing a catheter into a systemic artery, for example the femoral artery, and this catheter, we can move this catheter up to the aorta if we like. So this is a direct measurement, and the catheter is connected to a manometer which measures the pressure. Or we can use the stethoscope and the sphygmomanometer, the blood pressure cuff, to use blood pressure indirectly in the systemic circulation, because not every time we will insert a catheter into a systemic artery in the patient to measure his or her arterial blood pressure. So this is the pressure in the aorta and also the pressure in the systemic arteries, but there is very little difference, which was described in a previous lecture. And this is the maximum aortic pressure, the systolic aortic pressure, which is 120 millimeters of mercury, and this is the minimum aortic pressure, which is 80 millimeters of mercury. So the red curve is the aortic pressure curve. The yellow curve is the left ventricular pressure curve, and these curves were described in details in previous lectures. This is how we measure again the blood pressure directly by introducing a catheter into a systemic artery. This is the pressure in the aorta. This is similarly the pressure, the blood pressure curve in the aorta. The minimum pressure is the diastolic pressure, which is normally 80 millimeters of mercury, and the maximum pressure is 120 millimeters of mercury. The maximum pressure is known as the systolic blood pressure because this is the pressure in the aorta while the left ventricle is in systole. The maximum pressure in the aorta is reached when the left ventricle is in the rapid ejection phase of systole. The aorta itself does not undergo systole and diastole. What undergoes systole and diastole is the left ventricle. But we describe the pressure in the aorta as systolic and diastolic because the systolic blood pressure in the aorta, this is the pressure, the maximum pressure in the aorta when the left ventricle is in the rapid ejection phase of systole, and the diastolic blood pressure, this is the minimum pressure in the aorta, which is normally 80 millimeters of mercury. This is how we measure pressure in the systemic circulation indirectly with the use of the sphygmomanometer. The sphygmomanometer is the device which measures the arterial blood pressure. There are three different types of sphygmomanometers. This is the mercury sphygmomanometer, this is the aneroid sphygmomanometer, and this is the digital sphygmomanometer, which is now commonly used in clinical practice. With the mercury and the aneroid sphygmomanometers, we have to use the stethoscope to use the arterial blood pressure, the systolic and the diastolic blood pressures. And this is how do we measure the blood pressure in the systemic arteries using the sphygmomanometer and the stethoscope, and this will be described to you in a practical session. Here again we have, these are the sounds, the Korotkow's sounds, which are heard when we measure the arterial blood pressure using the sphygmomanometer and the stethoscope, and this will be described to you in the practical session. We usually describe the arterial blood pressure as the systolic blood pressure by the diastolic blood pressure. This doesn't mean that we divide the systolic blood pressure by the diastolic blood pressure. It is just a way of describing the arterial blood pressure. The systolic blood pressure, this is the maximum level of the arterial blood pressure in the systemic arteries, and as I've just mentioned, it is reached during the rapid ejection phase of ventricular systole. In a normal adult, it's about 120 millimeters of mercury, but it might range from 90 to 140 millimeters of mercury. See, the normal range for the systolic blood pressure is 90 to 140 millimeters of mercury. The diastolic blood pressure, it is the minimum level of blood pressure in the systemic arteries. it is reached just before the left ventricle opens the aortic valve and begins ejecting blood into the aorta. Hence, this diastolic blood pressure, the minimum level of the blood pressure in the aorta and the systemic arteries, is actually reached during the isometric contraction phase of ventricular systole. However, we still call it the diastolic blood pressure. For a normal adult, the diastolic blood pressure is about 80 millimeters of mercury, and the normal range is from 60 to 90 millimeters of mercury. The mean arterial blood pressure, this is the average pressure during the entire heartbeat, during the entire cardiac cycle, which drives blood into the tissues through the cardiac cycle. And we mentioned in the 2 lectures on the cardiac cycle that the mean arterial blood pressure is not halfway between the systolic and the diastolic blood pressure, because the arterial blood pressure remains closer to the diastolic than to the systolic blood pressure for a longer period of each heartbeat. This is the equation which we use to calculate the mean arterial blood pressure, and there is another equation which we described in the 2 lectures on the cardiac cycle. The mean arterial blood pressure tends to increase with age because of an age-dependent increase in the total peripheral resistance, which is controlled primarily by the arterioles, as we will describe in the subsequent slides. The pulse pressure, this is the difference between the maximum systolic pressure and the minimum, the diastolic pressure. For a normal adult, the pulse pressure is thus equivalent to 120 minus 80, which is 40 millimeters of mercury. The pulse pressure, this is the pulsatile component of the arterial blood pressure. It is determined by 2 parameters. The important parameter is change in the volume. And as the volume of the blood ejected into the aorta increases, this would increase the pulse pressure. Change in the volume is delta V, and delta V could be approximated as the stroke volume. So in other words, the larger the stroke volume ejected by the left ventricle into the aorta, the higher would be the pulse pressure. The other important factor which determines the pulse pressure is the compliance of the large arteries, is the compliance of the systemic arteries. Compliance is how the arteries can expand and accommodate the ejected stroke volume. This is again the pulsatile component of the arterial blood pressure. The maximum blood pressure in the aorta and the systemic arteries is the systolic blood pressure, and the systolic blood pressure, it keeps on decreasing, and the decrease actually begins during the slow ejection phase, as we described in the 2 lectures on the cardiac cycle, and the pressure keeps on decreasing during ventricular diastole, and the minimum blood pressure is reached just before the left ventricle again opens the aortic valve and begins ejection again. So the diastolic blood pressure is normally 80 millimeters of mercury, and again when the left ventricle opens the aortic valve and ejects blood into the aorta, ejects the stroke volume into the aorta, the blood pressure elevates from 80 to reach a maximum systolic blood pressure of 120 millimeters of mercury. So blood pressure in the systemic arteries keeps on pulsating from a minimum value of 80 millimeters of mercury, the diastolic blood pressure, to a maximum value of 120 millimeters of mercury, which is the systolic blood pressure. So this pulsatile component of the arterial blood pressure in the systemic arteries is the pulse pressure. This is the pulse pressure in a normal subject, and this is the pulse pressure when there is arteriosclerosis or atherosclerosis, where there is hardening of the arteries and the arteries have less compliance. They cannot expand well to accommodate the stroke volume. And when the arteries cannot accommodate well to expand to accommodate the stroke volume, the systolic blood pressure would reach a higher value than in normal subjects. So in atherosclerosis and arteriosclerosis, pulse pressure tends to increase with aging because of a decrease in arterial compliance as a result of hardening of the arteries. In cases of aortic regurgitation, because the incompetent aortic valve doesn't close properly at the end of ventricular systole, blood flows backwards from the aorta into the left ventricle during diastole. As a result, the diastolic blood pressure falls to a very low levels. So here we have a patient with aortic regurgitation where the diastolic blood pressure is approximately 40 millimeters of mercury. However, in patients with aortic regurgitation, the systolic blood pressure is higher than normal. And what makes the systolic aortic pressure higher than normal in patients with aortic regurgitation? Because during ventricular diastole, the left ventricle gets filled with blood from the left atrium. And also blood regurgitates from the aorta into the left ventricle. So the left ventricle would be filled with larger volume of blood during diastole. Hence, during the subsequent systole, which follows diastole, the blood pressure would be elevated to a higher level because the ejected volume, the stroke volume, would be higher than normal. However, this stroke volume, as we mentioned in the 2 lectures in the cardiac cycle, mostly will regurgitate. Up to maybe sometimes, in some cases, 60 to 70% of this large ejected stroke volume can regurgitate back into the left ventricle because of the incompetency of the aortic valve. It is easier to measure the blood pressure in the systemic arteries because we can measure the pressure in the systemic arteries indirectly with the use of the sphygmomanometer. However, in the pulmonary circulation, we cannot use the sphygmomanometers because all the arteries which are present in the periphery, these are systemic arteries, and the pulmonary arteries, they go into the lungs. So the only way to measure the pressure in the pulmonary circulation is by inserting a catheter into a vein, and the catheter can be moved to reach the right atrium and then the right ventricle and the pulmonary artery. This catheter is known as the Swan-Ganz catheter. It is named after the 2 people, Swan and Ganz, who first invented this catheter. So this is the pressure in the right ventricle with Swan-Ganz catheter in the right ventricle, and this is the pressure in the pulmonary artery with Swan-Ganz catheter in the pulmonary artery. This table summarizes and compares and contrasts the pressures in the systemic and pulmonary circulations. The pressure in the right ventricle is approximately 25 by 0. Again, we describe the pressures by describing the systolic blood pressure by the diastolic blood pressure. It is 25 during systole and approximately 0 or 2 to 3 millimeters during diastole. While the pressure in the left ventricle is 120 during systole and 0 during diastole. 0 means atmospheric, or 3 to 12 millimeters of mercury during diastole. The pressure in the pulmonary artery is 25 by 10 millimeters of mercury, while in the aorta it is 120 by 80. So the pressure in the aorta is approximately 6 to 7 times higher than the pressure in the pulmonary artery. This is because, as we mentioned earlier in the lectures, that the systemic vascular resistance is 6 to 7 times higher than the pulmonary vascular resistance. Thus, the pressure in the aorta should be 6 to 7 times higher than the pressure in the pulmonary artery in order to overcome the high resistance in the systemic circulation. Hence, the left ventricle should work harder than the right ventricle in order to generate the higher pressure required to overcome the systemic vascular resistance. The mean pulmonary artery pressure is approximately 15 millimeters of mercury, and the mean systemic arterial blood pressure is approximately 93 millimeters of mercury, and we have described how we calculate the mean arterial pressures. The pressure in the pulmonary capillaries is about 7 to 9 millimeters of mercury. This is the hydrostatic pressure in the pulmonary capillaries, and this must have been described to you in the respiratory block. The hydrostatic pressure in the systemic capillaries, in the capillaries which we have in the skeletal muscles, it is approximately 30 millimeters of mercury, and in the glomerular capillaries it is about 45 to 50 millimeters of mercury, because hair filtration is very important in the glomerular capillaries. The pressure in the pulmonary veins is normally approximately 5 millimeters of mercury, and in the peripheral systemic veins is about 7 to 15 millimeters of mercury. Pressure in the left atrium is about 5 to 10 millimeters of mercury, and in the right atrium the pressure is known as the central venous pressure, is about the atmospheric pressure. It is zero pressure. Hence, the pressure gradient in the pulmonary circulation, which is the difference between the mean pulmonary arterial pressure and the pressure in the left atrium, because this is the force which moves blood along the pulmonary circulation from the pulmonary artery to the left atrium. It is the difference between the mean pulmonary pressure and pressure in the left atrium. So it is the difference between the mean pulmonary pressure is 15 and the left atrial pressure is 5, so it is about 10 millimeters of mercury. The pressure gradient in the systemic circulation, this is the difference in pressure between the mean arterial blood pressure, which is 93 millimeters of mercury, minus the pressure in the right atrium. And this is the force which drives blood along the systemic circulation, because systemic circulation begins in the aorta and it ends in the left atrium. In the aorta, the mean pressure is the mean arterial blood pressure, which is 93 millimeters of mercury, and in the right atrium the pressure is 0 millimeters of mercury. Hence, the pressure gradient in the systemic circulation is 93 millimeters of mercury. We do have physiological variation in blood pressure. We mentioned that the systolic blood pressure ranges from 90 to 140 millimeters of mercury, while the diastolic blood pressure normally ranges from 60 to 90 millimeters of mercury. Age has got an influence in blood pressure. At birth, the blood pressure in a newly born infant is approximately 50 by 30 millimeters of mercury. In normal adults, as we mentioned, the blood pressure is 120 by 80 millimeters of mercury. And as we get older, the pressure increases, and in old age the pressure might be 170 by 90 millimeters of mercury. Sex also has got an influence on blood pressure. Males have higher blood pressure than females before the menopause. The body build has got also an influence on blood pressure. The pressure is higher in obese subjects. Emotions, excitement increases blood pressure. Exercise increases also the blood pressure. These are physiological variations in blood pressure. After meals, also the blood pressure increases. On the other hand, when someone is relaxing and sleeping, the blood pressure decreases. Gravity has also an influence on blood pressure. Because of the effect of gravity, the pressure in any vessel below the heart increases, while the pressure decreases above the level of the heart. And these effects, these changes in pressure, because of the effects of gravity. The gravitational effect can be calculated. It is equivalent to 0.77 millimeters of mercury per centimeter at the normal density of the blood. Hence, in an adult human who is in the upright position, who is standing, if the mean arterial blood pressure at the level of the heart is 100 millimeters of mercury, the mean arterial blood pressure in an artery at the head, so it is above the level of the heart, an artery at the head which is 50 centimeters above the heart would be 100 millimeters of mercury at the level of the heart minus 0.77 multiplied by 50. This is the effect of gravity, and here we have the pressure in the artery which is 50 centimeters above the level of the heart. We can similarly calculate the pressure in a vessel below the level of the heart, applying the same principle. So now let's describe what are the factors which determine blood pressure in the systemic circulation. Flow in the systemic circulation is directly proportional to the pressure gradient in the systemic circulation. The pressure gradient in the systemic circulation is the difference in pressure between the mean arterial pressure and the pressure in the right atrium, as we have just described. And we mentioned as this pressure gradient increases, flow increases, because this is the force which moves blood along the blood vessels as it has left the heart. As blood flows through the systemic arteries, it meets resistance, and the resistance resists flow through the systemic circulation. Thus, flow in the systemic circulation is inversely proportional to the resistance. The flow through the systemic circulation is the cardiac output. Cardiac output, we know that it is the volume of the blood which is pumped by the left ventricle into the aorta in minute. The units which we use to express the cardiac output could be liter per minute, which is in a normal resting adult is 5 liters per minute, or we might use the milliliter per minute. All of the cardiac output flows through the systemic circulation. Therefore, flow through the systemic circulation is equivalent to the cardiac output. So instead of the flow in this basic equation of the flow, we can put the cardiac output. The delta P is the pressure gradient which is the difference between the mean arterial pressure and the right atrial pressure. The pressure in the right atrium is equivalent to the pressure in the big veins closer to the right atrium, and hence the delta B can be calculated as the mean arterial pressure minus the central venous pressure. The pressure in the right atrium and in the big veins emptying into the right atrium is atmospheric, as we have just described, is zero. Hence, this pressure gradient is essentially equivalent to the mean arterial pressure. The mean arterial pressure drives blood in the systemic circulation, as we mentioned. Therefore, the mean arterial pressure is the delta P. So instead of delta P in this basic equation of the flow, we can put mean arterial pressure. So instead of the flow, we can put cardiac output, and instead of the delta P, we can put mean arterial pressure. R is the total peripheral resistance. Thus, cardiac output, flow is the cardiac output, is equivalent to the mean arterial blood pressure, delta V, divided by the total peripheral resistance. Thus, again, here we have the same equation. Cardiac output is equivalent to the mean arterial blood pressure divided by the total peripheral resistance. From this equation, the mean arterial blood pressure is equivalent to the cardiac output multiplied by the total peripheral resistance. And we know that the cardiac output is equivalent to the stroke volume multiplied by the heart rate. So from these two equations, especially this equation, the mean determinants of the arterial blood pressure are the cardiac output and the total peripheral resistance. What is the total peripheral resistance? How do we calculate the resistance which the blood meets as it flows through the systemic circulation? Poiseuille's law, this is a French scientist, states that resistance is equivalent to 8 multiplied by L, L is the length, blood vessel length, multiplied by eta, these are Latin letters, eta is the viscosity, divided by pi multiplied by the 4th power of the radius. So instead of R here, in this basic equation of flow, we can put R as 8 multiplied by L multiplied by eta divided by pi multiplied by the 4th power of the radius, according to Poiseuille's law. If the viscosity increases, resistance increases from this relationship. On the other hand, as the resistance decreases, flow increases. If viscosity increases, resistance increases. And since we divide by the resistance, flow decreases. The viscosity of the blood is determined by the hematocrit and the plasma protein concentration. If the radius of a vessel increases, the resistance decreases and the flow increases. And the radius has a tremendous effect on blood flow because the resistance is dependent on not only the radius, rather the resistance is dependent on the 4th power of the radius. Thus, if the radius is doubled, the resistance is reduced by 16 times, and flow would have increased by 16 times. What are the factors? Thus, since having known that the radius has a tremendous effect on the resistance, what are the factors then which affect the vessel diameter? We have vasodilator agents like nitric oxide, histamine, atrial natriuretic peptide, and prostaglandin I2, which is also known as prostacyclin. And we have vasoconstrictor agents including norepinephrine, angiotensin II, vasopressin, which is antidiuretic hormone ADH, endothelin 1, and thromboxane A2. Nitric oxide is an important vasodilator agent. Shear stress. This is the stress on the endothelial lining of the blood vessels as blood flows along the blood vessels. Usually the stress is perpendicular to the surface. However, as blood flows along the blood vessels, the stress which is exerted by the moving blood on the endothelial lining of the blood vessels is parallel to the blood, is parallel to the moving blood, is parallel to the blood vessel wall. And this is what we call in biophysiological terms the shear stress. Shear stress causes the endothelium to release nitric oxide. Nitric oxide is produced by the endothelial cells lining the blood vessels. And nitric oxide allows large blood vessels like the aorta to regulate flow in the absence of any metabolic signals, because metabolic regulation is important, and this will be described in a separate lecture. However, the aorta is not in direct contact with the tissues of the body. Hence, the aorta is not influenced by the metabolic regulators, it's not influenced by the metabolic signals. So nitric oxide is then important. It allows large blood vessels like the aorta to regulate flow in the absence of these metabolic regulators. Increased velocity of the flow increases shear stress, hence increases the release of nitric oxide, the vasodilators, nitric oxide in particular. This is an endothelial cell. This is the shear stress. And here we have nitric oxide is produced in an endothelial cell. Nitric oxide is produced within the endothelial cells from L-arginine. L-arginine is an amino acid, and within the endothelial cells we have an enzyme known as endothelial nitric oxide synthase. This enzyme produces nitric oxide. Nitric oxide then diffuses from the endothelial cells and acts on the smooth muscle cells which are present in the tunica media. And when this happens, nitric oxide activates an enzyme known as guanylate or guanylyl cyclase within the smooth muscle cells in the tunica media. Guanylate cyclase converts guanosine triphosphate to guanosine monophosphate. Guanosine monophosphate activates guanosine monophosphate kinases. And when this happens, the contraction of the smooth muscle cells in the tunica media is inhibited. And when contraction is inhibited, the smooth muscle cells in the tunica media undergo relaxation and resulting in vasodilatation, because when the smooth muscle cells relax, the blood vessel dilates. Here we have again nitric oxide produced from L-arginine in the endothelial cells, then diffusing to affect the smooth muscle cells in the tunica media. There are some drugs which work through the production of nitric oxide, and these drugs would thus produce vasodilatation. What is the mechanism of action of the agonists which work through the production of nitric oxide? The agonist binds to receptors on the endothelial cells. Binding of the agonists to the receptors on the endothelial cells stimulates the production of nitric oxide synthase enzyme. Nitric oxide synthase, as I've just mentioned, catalyzes the production of nitric oxide from L-arginine. Nitric oxide then diffuses through the endothelial cell wall and acts to stimulate guanylate cyclase in the vascular smooth muscle cells in the tunica medium. The stimulated guanylate cyclase catalyzes the production of cyclic GMP from GTP, guanosine triphosphate. Cyclic GMP is an important smooth muscle relaxer, resulting in vasodilatation. Viagra works by blocking the breakdown of cyclic guanosine monophosphate. So guanosine monophosphate, which is formed inside the smooth muscle cells of the arterioles, is not broken down. So its level is kept high, thereby inducing vasodilatation and increasing blood flow. However, we should note that overproduction of nitric oxide is dangerous because it can result in hypotension as a result of the massive vasodilatation which can induce. So we have mentioned that the most important factors which determine the arterial blood pressure are the cardiac output and the total peripheral resistance. And we mentioned that the most important factor which determine the resistance is the radius of the blood vessel. And we described the agents which cause vasodilatation and the agents which cause vasoconstriction. There are other factors which determine blood pressure. One important factor is the blood volume itself. An increase in the blood volume increases the cardiac output, and since the cardiac output is increased, because it is a main determinant of arterial blood pressure increases. On the other hand, a decrease in the blood volume, as in hemorrhage and as in dehydration, lowers the venous return, lowers the blood which returns to the ventricles, hence lowering the cardiac output and therefore the arterial blood pressure. Elasticity of the blood vessels is another important factor determining the blood pressure. Changes in the elasticity of the great vessels, the big arteries, affects arterial blood pressure. The aorta is an elastic artery, and I mentioned this elasticity of the aorta is important because it allows the aorta to accommodate the stroke volume when the left ventricle ejects the stroke volume into the aorta. So the aorta expands and accommodates the stroke volume. And this expansion of the aorta during the rapid ejection phase of the cardiac cycle, in order to accommodate the stroke volume, prevents the systolic blood pressure from being rising to a very high level. On the other hand, when the left ventricle begins diastole and the aortic valve closes, the aorta recoils back. And this recoiling of the aorta is important to maintain the diastolic blood pressure. So in atherosclerosis or arteriosclerosis, there is a decrease in the elasticity in the compliance as a result of hardening of the arteries. This makes the arteries behave like a tube. So during systole, as blood is ejected, as the stroke volume is ejected into the arteries, they do not distend as normal, and the pressure increases significantly, increasing the pulse pressure as we described it earlier. Since blood pressure is a very important physiological characteristic of our body, it should be very well regulated. So now let's describe how blood pressure is regulated. Blood pressure, we mentioned that we do have physiological variations in blood pressure. We do also have variations of the blood pressure over 24 hours. It is lower during sleep, and it is higher when someone is awake, especially when he is under stress. Blood pressure is well regulated. It should be well regulated. Why? This is in order to provide the organs of the body, especially the brain, with adequate perfusion pressure. And in order also to optimize cardiovascular work. Remember, the mean aortic pressure is the afterload which the left ventricle faces as it begins systole. And the left ventricle has to generate pressure to overcome this afterload and opens the aortic valve and begins ejecting blood into the aorta. So an increase in the mean aortic pressure, the mean arterial blood pressure, increases the afterload on the left ventricle. And this is not good for the left ventricle, because the left ventricle would have to work harder, as we explained in the previous lectures. Regulation of blood pressure is important, as we mentioned, because too low a value of arterial blood pressure, when there is hypotension, blood flow to the tissues will be reduced. For example, blood flow to the brain will be reduced, and this might induce fainting. On the other hand, too high a value of arterial blood pressure, which we call hypertension, is also not good, because this might cause, if the high pressure in the arteries reaches the capillaries, this might cause excessive capillary pressure and damage. And in the heart, the high blood pressure might result in myocardial infarction as a complication, renal failure, stroke, and changes in the retina, which we call it hypertensive retinopathy. So blood pressure should be then well regulated. How blood pressure is regulated? There are short-term mechanisms which act within seconds to minutes to regulate blood pressure, and these mechanisms are largely neural, and they regulate cardiac function and arterial diameter. So they regulate the heart rate and the force of left ventricular contraction. So they control then and regulate the cardiac output, and they regulate the arteriolar diameter. So they regulate the resistance, because again, the main determinants of the blood pressure, as we mentioned earlier in the lectures, are the cardiac output and the peripheral resistance. Blood pressure, mean blood pressure, is equivalent to the cardiac output multiplied by the total peripheral resistance. These neural mechanisms are the arterial baroreceptor reflex, the arterial chemoreceptor reflex, the central nervous system ischemic response, and the atrial reflexes. And we will describe these in details in the subsequent slides. We mentioned that another important factor which determines the arterial blood pressure is the blood volume. So we have intermediate and long-term mechanisms for regulating arterial blood pressure, which work from minutes to days, and these are largely renal, by the kidney, and hormonal, and they regulate blood volume. The catecholamines, which are released from the adrenal medulla, the epinephrine, and the slightly norepinephrine, which is released from the adrenal medulla. The epinephrine is considered as a hormone, and epinephrine acts through regulating the cardiac function and the arterial diameter, as we will describe. Other hormones act by regulating the blood volume. Other hormones involved in blood pressure regulation, and We will describe this in the subsequent slides. So let's begin with the short-term regulatory mechanisms of arterial blood pressure and describe the arterial baroreceptor reflex. It is a reflex, so it should begin with receptors which monitor the arterial blood pressure and detect changes in the arterial blood pressure. Changes in the mean arterial blood pressure are detected by baroreceptors. Baro means pressure, so these are pressure receptors which we have in the arch of the aorta and in the carotid sinuses. At the carotid sinuses and also in the arch of aorta. These receptors, they provide information to the cardiovascular centers in the medulla oblongata about the degree of stretch because of the changes in pressure. And the centers which we have in the medulla oblongata, as we described in the previous lectures, they are bilaterally located in the medulla oblongata. One of them is known as the cardioacceleratory center, which is sympathetic in nature, and the other one is the cardioinhibitory center, which is parasympathetic in nature. The carotid baroreceptors are located in the carotid sinuses on both sides of the neck, and the aortic baroreceptors are located in the arch of the aorta, as I just mentioned. This diagram shows the activity of the arterial baroreceptors. So on the y-axis we have the pressure, and on the x-axis we have the activity of the baroreceptors in the form of action potentials generated in the nerves which arise from these baroreceptors. From this diagram, it is shown that at normal arterial pressure, this is the normal arterial blood pressure, diastolic 80 and systolic 120 millimeters of mercury, baroreceptors are active because still there are action potentials which are generated by the baroreceptors and transmitted through the nerves to the cardiovascular centers in the medulla oblongata. Increased pressure, this is an increased pressure, this increases the rate of firing of action potential, while on the other hand, decreased pressure decreases the rate of firing. So when the cardiovascular centers in the medulla oblongata receive low frequency action potentials from the baroreceptors, they would know that the blood pressure must have decreased. And when they receive high frequency action potentials from the baroreceptors, they would have known that the blood pressure should have increased. The baroreceptors play an important role in maintaining relatively constant blood flow to the vital organs like the brain during rapid changes in the pressure. For example, when someone stands up suddenly from the supine, from the lying down position, the baroreceptors are important to maintain relatively constant blood flow to the brain. That's why they are called pressure buffers. Otherwise, if the baroreceptors are not functioning properly, when someone stands quickly from the supine position, from the lying down position, he might faint as a result of decreased blood flow to the brain. Here we have a diagram which summarizes the arterial baroreceptor reflex. So the reflex begins with the baroreceptors detecting changes in the arterial blood pressure and sending information to the cardiovascular centers in the brainstem, in the medulla oblongata, and then the centers in the medulla oblongata would respond to the changes in the blood pressure by changing the cardiac function, by changing the heart rate and stroke volume, in other words, by changing the cardiac output, and by changing the resistance, by changing the radius diameter, the vessel diameter, and by changing the vessel diameter, they change the resistance. And the cardiac output and the resistance are the two determinants of the blood pressure. So this will bring about change in the blood pressure back to the normal level or closer to the normal level. So when the arterial blood pressure is increased, firing of action potentials from the arterial blood receptor increases, and this increased frequency of action potential reaches the cardiovascular centers in the medulla oblongata. The cardioacceleratory center would be inhibited as a result of the increased blood pressure, so the sympathetic outflow to the heart, arterioles, and veins decreases. And when the cardioacceleratory center, which is sympathetic, is inhibited, the cardioinhibitory center, which is parasympathetic, is automatically stimulated, resulting in an increase in the parasympathetic outflow to the heart. Here we have again a summary of the arterial baroreceptor reflex. An increase in the mean arterial pressure increases the rate of firing of action potential from the baroreceptors. So the cardiovascular centers in the medulla oblongata would receive high frequency action potentials, and they would have known that the mean arterial blood pressure would have increased. As a result, the cardioacceleratory center is inhibited, resulting in a decreased sympathetic activity. The decreased sympathetic activity results in slowing of the heart, and with decreased sympathetic activity, the left ventricle would eject less stroke volume because of the decreased contractility, and the decreased heart rate together with the decreased stroke volume would result into decreased cardiac output. And the smooth muscle cells of the arterioles, when they receive less sympathetic activity, they would undergo relaxation, and the diameter of the radius then increases, and the diameter of the radius then increases, and the increase in the diameter and the radius of the arterioles would lower the resistance. So the decrease in the heart rate and the decrease in the stroke volume decreases the cardiac output, and the decrease in the cardiac output together with the decrease in the total peripheral resistance lowers the mean arterial blood pressure. So the mean arterial blood pressure now is lowered back to normal or closer to the normal value. The heart rate is lowered because also of the increased parasympathetic vagal activity to the heart as a result of stimulation of the cardioinhibitory center. So the heart rate is lowered when the arterial baroreceptor reflex is activated as a result of an increase in the mean arterial blood pressure, because of the decreased sympathetic activity to the sinoatrial nodal cells and the increased parasympathetic vagal activity to the sinoatrial nodal cells. Stroke volume is decreased because of the decreased sympathetic activity to the contractile cardiac myocytes. Here we have the opposite scenario when the mean arterial blood pressure is decreased. So we have low frequency action potentials from the baroreceptors going to the cardiovascular centers in the medulla oblongata. The result is increased sympathetic activity to the sinoatrial nodal cells, accelerating the heart, and to the contractile myocytes, increasing the force of contraction, and hence the stroke volume. Cardiac output is thus increased. With the increased sympathetic activity, the smooth muscle cells of the arterioles, these smooth muscle cells would contract, so the arterioles would undergo arteriolar constriction. The radius or the diameter is decreased, and the resistance increased, and the mean arterial blood pressure hence increases. With the increase in the mean arterial blood pressure, now flow to the heart and the brain is maintained. The vasoconstriction would be much in the non-vital organs. So this will reduce blood flow in the non-vital organs, and as a result, the pressure will increase. Well, the pressure would be elevated at least to more than the lowered level. And now this elevated pressure is important to push blood through the coronary circulation and the cerebral circulation in order to maintain flow to the heart and the brain. The arterial baroreceptor reflex is important in maintaining the mean arterial pressure constant during changes in the body posture, during changing in the position, as I just mentioned. When someone changes his posture, his position, from the lying down position, from the supine position to the standing to the erect position, because of the effect of gravity, a drop in the mean arterial blood pressure in the arteries in the head and in the upper part of the body will occur. The baroreceptor reflex is then activated, resulting in strong sympathetic impulses. These would cause vasoconstriction, and this minimizes the drop in the mean arterial blood pressure, hence maintaining a constant blood flow to the brain. Here we have the cardiovascular changes which are initiated by the arterial baroreceptor reflex in hemorrhage, and these cardiovascular changes are important when someone loses blood in hemorrhage. So hemorrhage blood loss decreases blood volume. When blood volume is decreased, the venous pressure is decreased, the venous return to the left ventricle decreases, so the atrial pressure decreases. The atrial pressure, this is the force which fills the left ventricle, and thus when this force is decreased, the left ventricular end diastolic volume is decreased, thus the stroke volume is decreased according to the Starling's mechanism. The decrease in the stroke volume decreases the cardiac output, and the decrease in the cardiac output lowers the arterial blood pressure. The lowered arterial blood pressure is detected by the baroreceptors, initiating the baroreceptor reflex. So we have increased sympathetic outflow to the heart and blood vessels, and decreased parasympathetic outflow to the heart. So here we have the heart rate. The control is before the subject bleeds, before hemorrhage. Then here what happens during hemorrhage, and here we have what happens as a reflex compensation when the arterial baroreceptor reflex is activated. So the heart rate, this is the heart rate before hemorrhage. During hemorrhage, the heart rate is not affected, and with compensation the heart rate increases because of the increased sympathetic outflow to the sinoatrial nodal cells and the decreased parasympathetic, decreased vagal influence on the sinoatrial nodal cells. Stroke volume, this is before bleeding. Stroke volume is decreased as a result of hemorrhage because of the reduced end-diastolic volume, and with compensation the stroke volume increases and goes towards the normal stroke volume because of the increased sympathetic outflow to the contractile myocardium, increasing the force of contraction of the left ventricle, and hence increasing the stroke volume. The cardiac output shows parallel changes to the stroke volume. So this is the cardiac output before hemorrhage. With hemorrhage, the cardiac output is decreased, and with compensation, the cardiac output increases and moves towards the normal cardiac output. The total peripheral resistance, this is before bleeding, this is during bleeding, or now with bleeding. With compensation, the total peripheral resistance increases because of the increased sympathetic outflow to the arterioles. So the smooth muscle cells in the arterioles undergo contraction, causing arteriolar vasoconstriction, reducing the diameter of the radius of the arterioles, elevating the resistance. This is the mean arterial blood pressure before hemorrhage. This is the arterial blood pressure with hemorrhage, is lower because of the decreased cardiac output, and during compensation, the mean arterial blood pressure is elevated and moves towards the normal arterial blood pressure as a result of the increased resistance and as a result of the increased cardiac output in compensation. Now, someone might say that the increase in the mean arterial blood pressure during compensation is not good, because this was done by the increase in the resistance. So the increase in the cardiac output is not beneficial to the tissues, because the resistance to the blood flow through the tissues has already increased. Well, this is not the case actually in the body. It is true that the total resistance has increased, but it is the resistance through the non-vital organs which has increased, thus increasing the total peripheral resistance, while the resistance in the cerebral circulation has not increased. So this is now important in order to maintain a constant flow through the cerebral circulation and constant flow to the brain when someone bleeds. So this is the mean arterial blood pressure before bleeding. This is during bleeding. This is the elevated mean arterial blood pressure as a result of compensation by the arterial baroreceptor reflex. Here we have the resistance in the brain. The resistance of the brain hasn't increased. Thus, the increase in the mean arterial blood pressure is now good to the brain, because now it pushes blood along the cerebral circulation and adequate blood flow reaches the brain. While the resistance in the gut has increased, the resistance in the skin has increased, the resistance in the kidneys have increased, because these are all non-vital organs when someone bleeds. So flow through the gut decreases, blood flow through the gut. Can you see? This is before bleeding, this is with bleeding, and this is with compensation for the flow through the gut decreases. And if this continues for some time, it can be problematic, as we will describe in one complete lecture. So we need to restore the blood volume. We need to give this the subject which has lost blood, we need to correct his blood volume. In the brain, this is blood flow through the brain before bleeding. During hemorrhage, it decreases, but now with compensation, blood flow through the brain increases, is elevated, and is approximately the same blood flow before bleeding. This is because the resistance through the cerebral circulation has not increased. The arterial baroreceptor reflex is important in short-term regulation of blood pressure. However, it is unimportant in long-term regulation of arterial blood pressure. The arterial baroreceptor reflex, it functions primarily as a short-term regulatory mechanism of the mean arterial pressure. It is activated at once, very quickly, by any blood pressure change. An attempt to restore blood pressure rapidly towards the normal level. Yet, if the mean arterial blood pressure deviates from its normal operating level for more than a few days, the arterial baroreceptors would adapt to this new blood pressure, whether elevated or decreased, and they reset their activity, and now the arterial baroreceptors would consider this new level of mean arterial blood pressure, which has remained for more than a few days, as the normal operating point for them. And thus, with adaptation of the receptors, there is a decrease in the impulse discharge from the receptors despite persistence of the stimulus. This adaptation of the baroreceptors obviously prevents the baroreceptors and the arterial baroreceptor reflex from functioning as a long-term blood pressure control system. The second important neural reflex, which is important in regulating, in the short-term regulation of the arterial blood pressure, is the arterial chemoreceptor reflex. We have chemoreceptors which detect changes in the partial pressure of oxygen, the partial pressure of carbon dioxide, and the hydrogen ion concentration. These chemoreceptors, they detect the chemical composition of the blood in the form of detecting the partial pressure of oxygen, partial pressure of carbon dioxide, and the hydrogen ion concentration. And that's why they are known as chemoreceptors. We have central chemoreceptors and peripheral chemoreceptors, as must have been described in the respiratory block. The supply of oxygen to the tissues, as you all know now, depends on both the cardiovascular system and the respiratory system. The chemoreceptors, they have a very high blood flow. Their blood flow is approximately 1,200 milliliters of blood per minute per gram of a tissue of the chemoreceptors. So this makes it easy for the cells, for the chemoreceptors, to detect changes in the partial pressure of oxygen, in the partial pressure of carbon dioxide, and in the hydrogen ion concentrations. Accordingly, when blood flow is reduced as a result of reduction in the mean arterial blood pressure, this would stimulate the chemoreceptors through oxygen lack and through increased hydrogen ion concentration and through increased carbon dioxide. Chemoreceptors are stimulated when the mean arterial pressure is lowered to levels than 60 millimeters of mercury. So they then work, these chemoreceptors and the arterial chemoreceptor reflex, as a second line short-term, a second line defense short-term mechanism, if you like, against changes in the mean arterial pressure. When they are stimulated as a result of the drop in the mean arterial blood pressure, the response is excitatory, not inhibitory. This means that when the arterial chemoreceptor reflex is activated by the reduced mean arterial pressure, there is increased sympathetic outflow. They reduce blood flow to unnecessary areas by increasing the resistance in these non-vital organs, and they protect the vital organs like the brain and the heart, because again, the resistance does not increase in the coronary circulation or the cerebral circulation. The resistance increases in the non-vital organ, and when this happens, the total resistance increases. And when the total peripheral resistance increases, the arterial blood pressure increases. And now this elevated arterial blood pressure is good for the brain and for the heart, because it would push blood along the cerebral and coronary circulation and provides the myocardium and the brain with adequate blood flow. Another important short-term regulatory mechanism of the arterial blood pressure is what is known as the central nervous system ischemic response. This response operates as an emergency arterial blood pressure control system, and it acts rapidly and powerfully to prevent further reduction in the mean arterial blood pressure whenever blood flow to the brain decreases to lethal levels. It is one of the most powerful activators of the sympathetic vasoconstrictor system. So when the mean arterial blood pressure is decreased to levels lower than 20 millimeters of mercury, as a result, for example, of massive bleeding, this will cause cerebral ischemia of the vasomotor center, of the cardiovascular centers in the medulla oblongata. And this would result in strong excitation of the vasomotor center. The vasomotor center is the sympathetic center in the cardiovascular centers. This strong excitation stimulation of the vasomotor center results from the accumulation of carbon dioxide and lactic acid as a result of reduced flow through the brain. The strong vasoconstriction of the blood vessels happens again in the non-vital organs, including the arterioles of the kidney, because the kidneys are not considered as vital organs when there is bleeding. And so this now elevates the resistance, the total peripheral resistance, to higher levels, elevating the mean arterial blood pressure in order to increase blood flow through the cerebral circulation. The central nervous system ischemic reflex, we call it the Cushing reaction, which was first described by Cushing. So, as you all know, brain is enclosed within the skull, within the cranium, which is a rigid structure. So there is no room for the brain to expand. Thus, an increase in the intracranial pressure as a result of a brain tumor or brain edema, this would compress the cerebral blood vessels. Hence, cerebral blood flow is decreased. This causes hypercapnia, an increase in the partial pressure of carbon dioxide in the blood vessels and the cerebral blood vessels. This will directly stimulate the pressor area. The pressor area is the area which eventually innervates the blood vessels of the vasomotor center, hence resulting in systemic vasoconstriction, increasing the total peripheral resistance with resultant increase in the mean arterial blood pressure. The resultant increase in the mean arterial blood pressure, which is coupled with the local cerebral vasodilatation, because carbon dioxide causes cerebral vasodilatation, will tend to restore cerebral blood flow back to normal, which is good for the brain. However, it is not good in some conditions which we will describe very briefly. So, the resultant rise in the mean arterial blood pressure, together with the local cerebral vasodilatation, will tend to restore cerebral blood flow back to normal. At the same time, the rise in the mean arterial blood pressure through the arterial baroreceptor reflex will reflexly decrease the heart rate. So, someone with increased intracranial pressure, if we check his pulse, we'll find that he has bradycardia. In fact, sinus bradycardia, one of the causes of sinus bradycardia is an increase in the intracranial pressure. This reflex is known as Cushing's reflex. If the increase in the intracranial pressure was due to edema caused by brain concussion as a result of damage to the capillaries, this is not good. This is now not good, because the increase in the cerebral blood flow induced by the Cushing reflex would increase the pressure in the cerebral capillaries, and this will cause further edema, and a vicious cycle is initiated. Now let's describe the fourth neural short-term regulatory mechanism of arterial blood pressure. This is the atrial volume receptor reflex, initiated by the atrial volume receptors. These are receptors located in the large veins close to the heart and also in the walls of the atria. They are sensitive to blood volume, thus the following mechanisms would occur to prevent excess elevation in the arterial blood pressure upon response to an increase of body fluid volume. An increase in blood volume stretches the atria of the heart, thus the atrial volume receptors are activated, resulting in action potentials transmitted through sensory afferent nerves to the cardiovascular centers in the medulla oblongata, inhibiting the cardiovascular centers. This results in decreased blood volume through the following mechanisms. Number one, there would be decreased sympathetic outflow or sympathetic drive to the kidneys. Thus, the afferent arterioles of the kidneys would dilate, and this increases the hydrostatic pressure in the glomerular capillaries. Hence, the glomerular filtration rate increases, so we have more filtration of the blood, and this lowers the blood volume towards normal. With the decreased sympathetic outflow to the kidneys, renin secretion is decreased, and you all know that renin is an enzyme which activates angiotensinogen in the blood, as was described in a previous lecture. Hence, the inhibition of renin secretion inhibits the renin-angiotensin-aldosterone system, resulting in inhibition of aldosterone production. Thus, blood volume is lowered towards normal. The other important mechanism which happens to prevent excess elevation of arterial blood pressure when the blood volume increases is the decreased secretion of antidiuretic hormone from the posterior pituitary. Thus, blood volume is lowered towards normal. Also, there would be an increase in the atrial natriuretic peptide. This is released from the atrial myocytes, as was described in a previous lecture, and this causes inhibition of the renin-angiotensin-aldosterone system, and it also causes vasodilatation, lowering the systemic vascular resistance. So now we have finished with the description of the neural regulatory mechanisms of arterial blood pressure, and we have known that these neural mechanisms are short-term regulatory mechanisms. Now let's describe hormonal regulation of arterial blood pressure. What are the hormones which are involved in arterial blood pressure regulation? The catecholamines, norepinephrine and epinephrine, adrenaline and noradrenaline, they are involved in the regulation of arterial blood pressure. A decreased mean arterial blood pressure results in increased sympathetic activity to the adrenal medulla. You know that the adrenal medulla is considered as part of the sympathetic nervous system. It is a modified sympathetic ganglion. Thus, secretion of epinephrine, adrenaline from the adrenal medulla increases, and this reaches the sinoatrial nodal cells, accelerating the heart rate and increasing the force of ventricular contraction, hence increasing the stroke volume. The catecholamines epinephrine and norepinephrine, adrenaline and noradrenaline, have adrenergic receptors in the smooth muscle cells of the blood vessels. They have alpha-1 adrenergic receptors, alpha-1 adrenoceptors, and beta-2 adrenergic receptors. Alpha-1 adrenoceptors stimulation promotes vasoconstriction, while stimulation of the beta-2 adrenergic receptors promotes vasodilatation. Noradrenaline, norepinephrine, which is released primarily from sympathetic nerve endings, binds primarily to the alpha-1 adrenergic receptors, while adrenaline, epinephrine, which is released primarily from the adrenal medulla, circulates in the blood and can bind to both the alpha-1 adrenoceptors and the beta-2 adrenoceptors. Adrenaline has got a greater affinity for the beta-2 adrenoceptors than for the alpha-1 adrenoceptors. Thus, at low concentration of adrenaline, at low concentration of epinephrine, there is preferential binding of epinephrine to beta-2 adrenergic receptors, causing vasodilatation. We mentioned that stimulation of the beta-2 receptors promotes vasodilatation. At high concentrations of adrenaline would bind to both alpha-1 and beta-2 adrenoceptors. Thus, it might either cause vasodilatation and or vasoconstriction. In the cardiac and skeletal muscles, arterioles, in the arterioles which we have in the cardiac tissue and in the skeletal muscles, there is more beta-2 receptors than alpha-1 receptors in the smooth muscle cells of the arterioles. Hence, adrenaline would thus promote vasodilatation. On the other hand, in most other tissues, in the arterioles of most other tissues, the smooth muscles of the arterioles, of course, have more alpha-1 receptors than beta-2 receptors, and accordingly, adrenaline would promote vasoconstriction. The other hormone which is involved in the regulation of arterial blood pressure is the antidiuretic hormone, the vasopressin, is also known as vasopressin. Antidiuretic hormone, the vasopressin, is a hormone which is synthesized within the paraventricular nucleus of the hypothalamus and then stored in the posterior pituitary. Vasopressin, it exerts a pressure effect on the arterioles because it induces contraction of the smooth muscle of the arterioles, hence arteriolar constriction, elevating the vascular resistance, hence elevating the arterial blood pressure. Vasopressin, the antidiuretic hormone, is released from the posterior pituitary in response to dehydration when someone is dehydrated, also in response to salt ingestion, and when the osmolarity of the blood as a result increases. The increase in blood osmolarity stimulates osmoreceptors in the hypothalamus, and upon stimulation of the osmoreceptors, the ADH is released from the posterior pituitary. ADH causes vasoconstriction, as I've just mentioned, and it also acts on the collecting ducts of the nephrons, promoting retention of water. By inducing vasoconstriction, ADH increases the total peripheral resistance, hence elevating the arterial blood pressure. And by promoting water retention by the collecting ducts of the nephrons in the kidneys, it increases the blood volume, hence increasing the venous return and the cardiac output, and the blood pressure is elevated. So we have finished then with the hormonal regulation of blood pressure, and now let's move on and describing renal regulation of arterial blood pressure. The baroreceptor reflex and the other reflex mechanisms are important for the short-term control of arterial blood pressure, as we mentioned in the previous slides. Long-term control of blood pressure requires control of blood volume, and the control of the blood volume is done by the kidneys, as we have briefly described in the previous slides. Within the kidneys, we have got an apparatus which is known as the juxtaglomerular apparatus, and there are cells in this apparatus in the afferent arterioles. These are modified smooth muscle cells known as the juxtaglomerular cells. These juxtaglomerular cells release renin in the blood in response to a drop in the arterial blood pressure. Renin acts on angiotensinogen released from the liver in the blood, converting angiotensinogen into angiotensin. Then as angiotensin circulates and reaches the pulmonary circulation, where we have in the capillaries of the pulmonary circulation, there is the angiotensin converting enzyme converting angiotensin 1 into angiotensin 2. Angiotensin 2 then has several effects. The angiotensin 2 enhances the sympathetic activity. It stimulates tubular sodium and chloride reabsorption and potassium excretion. And when sodium and chloride reabsorption is increased, water follows, resulting in water retention, hence blood volume increases. Angiotensin 2 also acts on the adrenal cortex, releasing aldosterone. Aldosterone causes more reabsorption of sodium and chloride, and again water follows, hence more water retention, thus blood volume increases. Angiotensin 2 also acts on the smooth muscle cells of the arterioles, causing arteriolar vasoconstriction, hence the resistance increases and the blood pressure increases. Additionally, angiotensin 2 stimulates the release of antidiuretic hormone from the posterior pituitary, and the antidiuretic hormone, as we just mentioned, acts on the collecting ducts of the nephrons, causing retention of water. Angiotensin, the ADH, which is the vasopressin, also causes arterial vasoconstriction. So the net effect of angiotensin 2 would be water and salt retention, hence the effective circulating volume increases, elevating the cardiac output and elevating the arterial blood pressure. And when the arterial blood pressure is elevated and is now moving towards the normal level, perfusion of the juxtaglomerular apparatus increases, and this now causes a decreased release of renin, because the secretion of renin was initially triggered by the drop in the arterial blood pressure, which causes a decrease in the renal perfusion, and hence a decrease in the perfusion of the juxtaglomerular apparatus. Thus, when now perfusion of the juxtaglomerular apparatus increases as a result of correction of the arterial blood pressure, renin secretion is inhibited. Here we have again a diagram which elaborates more on the actions of angiotensin II. So angiotensin II causes constriction of the efferent arterioles in the kidneys. These are the afferent arterioles and these are the efferent arterioles. And when the efferent arterioles are constricted, the pressure in the glomerular capillaries increases, and hence filtration increases, while the pressure in the peritubular capillaries is reduced. And when the pressure in the peritubular capillaries is reduced, this reduces the resistance to tubular reabsorption, because the hydrostatic pressure in the peritubular capillaries opposes reabsorption in the tubules, as will be described to you in the renal block. So now we have more tubular reabsorption, resulting in reduced urine volume. But when we have more tubular reabsorption, we have retention of water in the body, elevating the blood volume, elevating the venous return and the cardiac output based on Starling mechanism, and hence the arterial blood pressure is elevated. Finally, let us very briefly describe what is meant by hypertension and hypotension. Sometimes the blood pressure control mechanisms, which we have described in details, do not function properly, or they are unable to completely compensate for the changes which have taken place in the arterial blood pressure level. Blood pressure level might be therefore above the normal range, and when this happens, the condition is termed hypertension. When the systolic blood pressure is above 140 millimeters of mercury and the diastolic blood pressure is above 90 millimeters of mercury. Or the blood pressure might be below normal, and this is termed hypotension if the blood pressure is less than 100 by 60 millimeters of mercury. Theoretically, hypertension might result from an increase in either the cardiac output or the total peripheral resistance, or in both the cardiac output and the total peripheral resistance, because the cardiac output and the total peripheral resistance are the main determinants of the arterial blood pressure. However, in reality, the major abnormalities in most cases of well-established hypertension is increased total peripheral resistance, which is caused by a reduced radius of the arterioles. Here we have classification of the blood pressure levels. So here we have the average systolic blood pressure, and here we have the average diastolic blood pressures. So the optimum blood pressure level is when the systolic is less than 120 and the diastolic is less than 80. The normal blood pressure levels is when the systolic ranges from 120 to 129, and when the diastolic ranges from 80 to 40. High normal when the systolic blood pressure ranges from 130 to 139 millimeters of mercury, and the diastolic from 85 to 89 millimeters of mercury. Now, these are the stages of hypertension. Stage 1 begins when the systolic blood pressure is now from 140 to 159, and the diastolic is from 90 to 99 millimeters of mercury. Obviously, stages 2, 3, and 4 would have higher levels of systolic and diastolic blood pressures. In only a small fraction of cases of hypertension, in about 5 to 10% of cases, the cause of arteriolar constriction is known. Hypertension, which occurs secondary to another primary problem, is known as secondary hypertension. The underlying cause is thus unknown in the remaining 90% of cases of hypertension. Such hypertension is known as primary hypertension or essential hypertension or idiopathic hypertension. The causes of secondary hypertension include renal diseases, which account for more than 80% of cases of secondary hypertension. We have endocrine causes of secondary hypertension, including the Conn's syndrome, adrenal hyperplasia, pheochromocytoma, Cushing's syndrome, acromegaly, and these will be described to you in details in the endocrine block. Coarctation of the aorta, this is an abnormality in the aorta. This also results in secondary hypertension. Some drugs cause elevated arterial blood pressure and hypertension, and pregnancy might also causes pregnancy-induced hypertension. Let me end this lecture by asking you a very important question, which is, what are the complications of hypertension? And I will leave this question for you to answer, but I will just remind you that when there is elevated arterial blood pressure, the afterload, the left ventricle has to work against elevates, and the left ventricle would have to work harder to overcome this elevated afterload. There are other complications of hypertension, and these will be described to you in other lectures. Here we have the intended learning outcomes of these very important learning activities, and thank you very much for listening.